First of all, it is a pleasure for me, of course, attend to this meeting. Today, during my talk, we are going to explore a fundamental tool in reproductive medicine, the three-dimensional sonohysterography. In infertility treatment, we know that a precise evaluation of the uterine cavity, it's not just an option, it is a necessity. So during the next few minutes, we will see how this tool allows us to visualize the uterine cavity with details, and it helps us make better clinical decisions for our patient. I have nothing to disclose. Our goal today is, of course, to understand, first of all, how to perform this technique. Then we will focus on our patient, so specifically infertility patient, and then we will see why this technique is often superior, identifying pathologies that could affect implantation. And finally, we will discuss the practical impact of this technique, so how integrating 3D sonohysterogram into our daily clinical routine can streamline the diagnostic process and improve our surgical planning. To understand, of course, where we are today, we must look at how far we have come. So here you can see just a quick timeline. Sonohysterogram was introduced at the beginning in early 19th, and Parsons and Callaghan already established the standardized criteria that we are still using today. But then the real game changer, however, has been the introduction of the 3D technology, which has moved us from the simple 2D section to a complete volumetric understanding of the uterus. So then, as we moved into 2000 and 2010, the focus shifted toward infertility, and today, as you can see at the end of my timeline, sonohysterogram is no longer just an optional tool, it is a cornerstone in our daily clinical practice. So, the benefits of this technique, of course, the sonohysterography generates acoustic shadows that allows the perfect visualization of the inside part of the uterus and in the same time also of the fundus. Also, the goal is clear, so to visualize the endometrial cavity in greater detail than what is possible with routine ultrasound. And this because if you cannot see it with a normal 2D scan, it doesn't mean that it doesn't there. Now let's go to the core of my talk. So, and why we are moving toward the 3D sonohysterography. This presentation demonstrates how 3D sonohysterography changes our perspective when combining the saline infusion with the volumetric plane. So as you know, the coronal view is the one that allows us to see the entire uterine cavity and the fundus simultaneously, and I will really insist about the concept of the coronal plane, as my colleague already did, for that, because it's really important. 3D sonohysterography offers a series of improvements, of course, over the 2D. It is possible to assess the uterine cavity and the external contour at the same time, as already said before. Also, we need less time for the realization of the sonohysterography because once the volume is obtained, it is possible to work also offline on the picture. So we need also a shorter period to distend the uterus, and this, of course, decreases the patient's discomfort. Beyond technical advantages, current evidence supports its clinical value, of course. This is a Cochrane from 2017 that concludes that the sensitivity and specificity of 3D sonohysterography is higher than a conventional sonohysterography. Then we also have an SRM updates that confirm 3D imaging as the reference standard for the uterine cavity assessment in infertile women. And then here you can see the appropriateness criteria by ACR that confirm like 3D sonohysterography is the most appropriate test for intracavity evaluation. To achieve the clinical results that, of course, we all want, we must follow standardized criteria. And luckily we have this by Measure Society, ACR, ACOG, AUM and SUR, that gives us the practice parameters to perform a night quality sonohysterography. So finally we have this clear consensus. And why the standardization is important? Because of course is what allows us to have findings that can be reproducibly and also globally recognized. So let's take a look how to perform a sonohysterography. First of all, clinical safety. That starts before the catheter is even opened, of course. It includes a preliminary transvaginal scan. During this scan, we always must assess for pelvic tenderness, and this is really important because if there is any suspicion of active inflammatory disease, the procedure must be cancelled or postponed. We also need to screen the patient for allergies, specifically latex or povidone, that is what we use at the beginning for the disinfection of the cervix. And then regarding the infection prevention, we don't use routine antibiotics for all patients because as the guidelines told us, we just need to base our decision on the patient's individual risk factor. For example, tubal patency, it's of course an indication to use antibiotic prevention. However, to improve the patient experience during our clinical practice, we strongly recommend a pretreatment with non-steroid anti-inflammatory drugs. Here you can see a video that just shows you how to perform a sonohysterogram. You can see the insertion of the catheter, and then it is a minimal invasive step. We use the same catheter that we are using during the anembryo transfer. And then you can see how the saline infusion slowly distends the cavity, creating our acoustic shadow. And while infusing, we perform in the same time a real 3D scan. And this is when the magic happens, because of course, then once the volume is saved, you can navigate through all the plans, as my colleagues showed before. So, about the standardizations, the parameters that the Measure Society gives us, another important thing is the timing of the procedure, because of course the timing it's not just a detail; it's the key diagnostic. It is important to give you the standardization of the technique. The ideal window to perform this exam is between day 5 and day 10 of the cycle, so during the early proliferative phase. Why? Because the endometrium is thinnest in this phase, so of course it avoids false positive, because we are more sure that the patient is not pregnant, and also because it minimizes blood clots that could mask pathology during our examination. Or maybe we can also do this exam under birth control pill. Before we proceed to the clinical cases, we must be clear on when to stop, so our contraindication. Of course, pregnancy is our absolute contraindication, our absolute red light. So this is why the timing is really important. Pelvic infection, or even unexplained tenderness that must be taken seriously, as the procedure could exacerbate, of course, this tenderness. And finally, active vaginal bleeding. Of course, this is not an absolute contraindication, but it's a practical one because, as mentioned before, blood clots can mimic or hide pathologies that make your volume much harder to interpret. So safety and image clarity always come first. Let's take a look at our indication. We can just group our indication in 3 main pillars. We have the infertility. And so in the infertility group, of course, it is essential, this tool, to detect adhesions or maybe micropolypoid endometrium, that could be a marker of hyperplasia or chronic endometritis, and adenomyosis that could impair implantation. Then we have congenital malformation. So as we mentioned, the 3D coronal plane, of course, is the gold standard. And then abnormal uterine bleeding, because of course it provides unmatched detail for identified polyps, fibroids, or even cesarean scar niches, which are often missed just with the normal 2D scan. So first of all, of course, let's define our baseline. Here you can see a perfect normal uterine cavity. On your left side, a cavity performed using 3D multiplanar reconstruction, and we can visualize sagittal, transverse, and importantly at the same time simultaneously the coronal plane. And notice the smooth triangular shape of the cavity and the straight fundal contour. On your right side, we are using the tomographic ultrasound imaging, so the TUI, and this is like a multi-slice approach, and it's incredibly helpful, of course, because it's like a CT scan that we can just perform during ultrasound. And why it's important? Because, of course, it allows us to scan through the entire volume in sub-millimeter increments, and so ensuring that no focal lesions are hiding between the standard planes. Here you have two other examples. On the left side, the HED Live that use a virtual light source to create realistic shadows and depth. And on your right side, you can see an HED Live silhouette that provides a glass body effect. By making the solid tissue semi-transparent, it allows us to see through the uterine wall. And so it's really useful. So let's take a look on our clinical cases. Our first clinical cases focuses on intrauterine adhesions, a major factor in secondary infertility and implantation failures, of course. In this image, you can clearly see how the saline infusion highlights fibrous bridges that cross the cavity. This is another case. While the 2D ultrasound might only just show you an irregular endometrium, during the 3D coronal reconstruction performing a sonohysterography, especially in the HED Live rendering that I will just show you, here you can map exactly the localization of the adhesion. And then here you can see how it perfectly corresponds to what we see during the hysteroscopy. In this case of adhesions, we can see a more complex scenario. Here the standard 2D views just show you a cavity that it's difficult to distend, that usually it suggests an Asherman syndrome. Then, however, the 3D coronal reconstruction helps to discover the appearance of this spider web that is typical of a cavity with an Asherman syndrome. Let's take a look about adenomyosis. This is often a silent enemy of implantation. Here you can see a comparison between a standard 2D scan in which the globular appearance of the uterus it's already evident, but then with the 3D sonohysterogram, the distension of the cavity helps us to check better the irregular boundary in the endometrium-myometrium junctional area. Finally, so with the coronal view, we perfectly illustrate the globular uterus and the irregular junctional zone. One of the most common patterns that we also encounter analyzing sonohysterography in infertile patients is an irregular endometrium. 2D scan and 3D scan normally cannot help you to identify the cause of the irregular endometrium. Then the use of the 3D sonohysterography immediately reveals the micropolypoid endometrium. And using tomographic ultrasound imaging, so the TUI on the left that you can see, you can scan, as I mentioned before, the entire cavity to see if there is changes, if these changes are focused or diffuse. And it may indicate endometrial hyperplasia, and so therefore we will give to patient the progesterone treatment. But it may also indicate chronic endometritis. And of course, in ART context, identifying these micropolypoid patterns allows us to treat the patient with target antibiotic and or maybe to perform a direct biopsy before proceeding with the embryo transfer, significantly reducing the risk of implantation failure. Here you can see the perfect correspondence between what you see during the sonohysterography and what you see during the hysteroscopy. Again, another cases, and again the perfect correspondence between what you see during the sonohysterogram and what you see during the hysteroscopy. In our clinical and research experience, sonohysterogram has a 99% concordance rate with hysteroscopy in identifying chronic micropolypoid endometrium, and this of course makes it an essential screening tool. Moving to the congenital uterine malformation, while a dedicated talk it was just follow on this topic, I would just like to add that 3D sonohysterogram adds, of course, the power of the cavity distension, so it helps us, as in the normal uterus, to detect any intracavity abnormalities that would be otherwise impossible to check with the normal 3D scan. What about our third pillar, so abnormal uterine bleeding? Here you can see a classic example of a sonohysterogram. When the saline begins to distend the cavity, you can already check, even in the 2D scan, that there is this focal lesion, an hyperechoic lesion immediately stands out. In a standard 2D scan without influsion, a polyp is of course just sandwiched between the endometrial layers, but then with the sonohysterogram you can identify it. So passing to the 3D volume, the polyp is no longer just a shadow. We can appreciate its real volume, the exact peduncle insertion, and maybe also measure it better. You can see it. And again, the perfect correspondence in what you see during sonohysterogram and what you see during hysteroscopy. Moving to the uterine fibroids, 3D reconstructions allows us to identify the exact position of the fibroid in 3 dimensions, and of course it's really useful for us to choose the type of surgery, and also allows us to assess how much and whether a fibroid impacts the cavity. Here you can see this example in TUI, and then the same patient. Here you can see a fibroid mapping during sonohysterogram that of course give you exactly the idea of the position of the myoma in the space in 3D. The true power of the 3D sonohysterograms lies in its sensitivity for even smallest lesion. So sorry, it's with audio, but it doesn't matter. So as you can see here, the saline distensions allows us to identify also teeny submucous fibroids. Sometimes just a few millimeters in size of these submucous fibroids that would otherwise be completely compressed, of course, and hidden by the endometrial layers in a standard scan. Here you can see it's really, really small. And then another example of submucosal myoma, measuring it approximately 8 millimeters. It was already visible during the 2D scan, but then with the 3D sonohysterogram we can better define its contour and also better define its position in relation to the uterine cavity. What about the evaluation of the C-section scar? Following the Delphi consensus by Jordans et al. From 2019. Sonohysterograms, of course, allows us to precisely measure the residual myometrial thickness. That it's really important for us to predict obstetric complication. When evaluating a C-section scar with a 2D ultrasound or even with a 3D ultrasound often fails to provide you a full picture. As you can see in this longitudinal comparison, then with the 3D sonohysterograms, we can distend the niche, providing a clear view of the residual myometrial thickness. And here again, the correspondence between the sonohysterogram and what you see during hysteroscopy. So at this point, having established that there is a perfect correspondence, of course, between what we see during the 3D sonohysterogram and the diagnostic and what we see during a diagnostic hysteroscopy, I would like to introduce you the concept of virtual hysteroscopy that it was already mentioned by Dr. Palumbo at the beginning of this morning. Simply changing the direction of the rendering line, this green one that you can see, and position the cavity and positioning it in the cavity entrance on the right, we can perform it, and this of course allows us to create an image comparable to what we see during a conventional diagnostic hysteroscopy. You can even see also the ostia and all the cavity. So of course maybe in many cases it will even replace a conventional diagnostic hysteroscopy. To conclude, these are the key messages that I would like to give you to take home. First, 3D sonohysterogram dramatically improves diagnostic accuracy through multiplanar visualization. It provides a superior surgical map, helping us choose the best approach and predict complication, especially performing the virtual hysteroscopy. It is a patient-friendly, non-invasive tool that should be considered at the first level in infertility workup. And finally, it offers an excellent cost-benefit ratio, and ongoing technological development, like for example 4D, are only going to further redefine the diagnostic precision. Thank you.